attending today, the fourth day of Global Health Week and Diversity Week too. So stop out inside and get a lunch if you don't have one, and also get a diversity cupcake, right? But today I have the pleasure of introducing two speakers, some of our trainees, and the first is a nursing student. This is Maleah Cline. She's a junior nursing student here at WVU, and we're so pleased to have nursing participate. Thanks so much in advance. And Maleah is going to talk about Estonian experience.
Hello, everyone. My name is Maleah. I am a second semester junior at the WVU School of Nursing. And today I'm going to be talking about the trip that I got to take to Estonia over spring break last semester. So I just want to thank you all for being here and thank you for listening. And if you have any questions, I will take them at the end of the presentation. So I received an email from the Global Health Program here at WVU regarding the trip, and I decided to apply. I didn't really have a reason to apply. I just thought it would be a fun thing to do. It was sent to students with health-related majors, and since I'm in the nursing program and I'm minoring in addiction studies, I was sent the email. So 21 different students of different majors, mostly healthcare and international studies related, went along with 2 faculty members in total. And we were hoping to learn about differences in healthcare, specifically with the opioid crisis. So on the screen here, I have some objectives that I would hopefully like you guys to pay attention to and learn about. So the first one, I hope you guys can identify similarities and differences between the US and Estonia regarding the opiate crisis, and then describe significant culture and history of Estonia, and then understand the dynamic and significance of the trip as a whole. So some basic questions that I'd like to answer are listed above here. So I decided initially that I wanted to go on the study abroad trip for a few reasons. Unfortunately, in August of 2022, my father unexpectedly passed away after his fight with his addiction to alcohol consumed his life. This wasn't the father I knew nor the father I remember, so I both minored in addiction studies and decided to go on this trip for him. I initially decided to minor in addiction studies because I have a lot of family history with addiction. I have had a few family members overdose or struggle with different addictions, so I wanted to go into this field in order to learn more about the process in the body and figure out ways to help others experiencing this struggle from both the addiction end as well as the family of the person with the addiction end. I was fortunate enough to apply for and receive a few scholarships for this program. Overall costs were a little under $4,000, and I knew that I would really have to think about how I was going to be able to afford this trip, especially considering the timing. I decided to look into scholarships I may be able to apply for, and I ended up receiving a scholarship from the WVU School of Nursing, as well as a scholarship from the Office of Global Affairs. I was extremely excited because without these scholarships, I would not have been able to go. Now, the last question, did I know anyone that was going on this trip? I knew absolutely nobody going. I went into this just for fun. I met a lot of people who had similar stories to mine, and I was one of 2 people who had never been on an airplane before at all. So going across the country for my first over abroad experience, especially I flew to Georgia. So we had like a layover. That was the first time I've been on an airplane, so that was very surreal. And here I was about to go to another country with 2 faculty members and 21 other students that I had never met. From the students, there were a variety of majors, some of which included nursing, exercise physiology, biology, political science, and a couple international studies students. We had 3 meetings before the trip in which we all met and learned about one another. And then throughout the week during spring break, which is when we went last semester, I learned a lot about every person that attended the trip and made some great friends. So this is Grant in Estonia. That's his Instagram up at the top. He was our quote unquote tour guide of the trip. So Grant is an alumni from WVU who after graduation received a scholarship from Fulbright to move to Estonia for a year and help teach English at a few schools. Fulbright is a program that gives students and those who have graduated opportunities around the world based on their graduating degrees. For Grant, he was able to teach English in 2 different schools and even tutored Ukrainian refugees in English after they came to Estonia for shelter. He runs the Instagram account to show his adventures and tell the public about what he is doing. And we were able to go on this trip because, like I said, Grant was basically our tour guide. Since he went to WVU, he knew Kristen Grog and Kate Johnson, who were the coordinators of the trip. And they decided to take all 21 of us to Estonia to learn about the differences in healthcare, especially with the opioid crisis. So this is just a brief history of Estonia. Not a lot of people knew about Estonia before we went. A lot of people, when I tell them I went, they're like, I didn't know that was a country to begin with. So a brief history. They were under all these rulers for a while from 1645 to 1992. And finally in 1992, they received their independence. And what's significant about this is throughout the time of protests and deportations that they experienced, the Estonians would actually line up across a majority of the country, which I'll show you a picture of how small the country actually is in a few slides. But they would link arms and sing their folklore songs and traditions. And this is why they were known as a country that sang their way to freedom. They never stopped singing, even throughout times of stress and desperation. And that's just a picture that I took while we were there. It's just this little Estonian family on one of our walks that we went to. I thought it was cute. So the next thing I want to talk about is the opioid crisis in Estonia. It is very similar to the crisis that we've experienced here in the United States, specifically West Virginia, which is a big part of why we decided to go to this country and not any other one. So the fentanyl crisis in Estonia began around 2001, where the majority of overdoses were from fentanyl. This began from a shortage of heroin in the country, and at the time, though the population was just merely past 1 million, the country had the highest rating of fatal overdoses in the European Union. Like in the US, specifically West Virginia, Estonians' main contributor to the crisis was injected fentanyl. The crisis lasted for about 10 years in the country, and like the US, government officials were trying to figure out how to combat it. However, the small country has since overturned the fatal history and is using many methods to continue towards progression. This diversion program here at the bottom is a police diversion program that has helped provide alternatives to punishment and instead support individuals who are dealing with addiction crises. It's a social support service that has a goal of improving the quality of life of those who are using drugs and was actually adapted from an American program in 2018. Basically, those who have committed drug-related offenses can be referred by police officials to a support peer group instead of serving jail time. The peers support their clients by actively listening to their history and helping them lean towards less risky actions. This usually lasts for about 12 months, and at the end, the peer determines if the individual is able to go back into society as a progressive member of the community or if further help and treatment are needed. Peers are chosen because they too have gone through their own personal experiences with addiction, and they use these experiences to help these individuals through this time. They can refer other resources to, like social services, if necessary. And this process has helped build a non-judgmental, safe space for these individuals, allowing them to build trust and get back into society. There are other things Estonia had tried doing prior that are more similar to the US, such as a needle exchange program, support groups, and of course, punishment. But this diversion program has deemed the most progressive, positive results. So here's the little picture of Estonia that I was telling you about. As you can see, it's very tiny. So you can imagine the millions of people just linking arms and singing their songs and singing their way to freedom. But I want to talk about diversity in Estonia since it is Diversity Week here. So the official language of Estonia is obviously Standard Estonian, but they do speak a lot of other languages every day. Most Estonians are actually taught English in primary school, so going to this new country was pretty easy in terms of communicating with those who live there. Other languages spoken include German, Russian, Swedish, and several dialects of the Estonian language as well. Diversity and inclusion has actually been a foundation of Estonia since 2012, when the Estonian Diversity Charter was founded. Diversity Day has been celebrated in the country since 2015, and in 2018, a workplace label, Respecting Differences, was actually launched. Since Estonia sits between Western and Eastern Europe, there are many cultural influences in the country. Towards the west is Sweden and towards the east is Russia, and it has many influences from both countries. Northern Estonia has been more open to outside influences, including Germanic Christianity and the Reformation. Southern Estonia is more provincial and insular. However, the country's agriculture has bridged this gap. Estonians and Russians make up the vast majority of residents in the country. However, other residents also include Ukrainians, the Finnish community, Germans, Latvians, Jewish communities, and Lithuanians. So this next slide, this picture, we went to one of the libraries that Grant actually helps tutor the Ukrainian students at. And all those books that you see us holding, we all brought them so that the Ukrainian students would have something to read in their language as well while they're, refugeeing in a different country. So some things we did, we had lunch at the Tallinn Teletorn, which is the radio station in one of the major cities, Tallinn. And it was really cool. We were all the way up in the sky. We toured it. It was awesome. We toured the Caltech University, which is just one of the universities over there. They focus on technology, and we got to see the classes that they took and all that fun stuff. They have a health museum over there, and we toured that. It is mostly for primary school and secondary schools, so we kind of, I don't know, it was more interactive than anything, but it was still really cool. We obviously went to the Drug Abuse and Infectious Disease Prevention Center meeting, and this is where we learned mostly about the opioid crisis in Estonia and learned about their interventions that they've been providing. We toured a school in Viljandi, which is one of the schools that Grant teaches at. We got to meet a bunch of the students. We actually got to sit in one of their classes and talk to them about the differences that they've learned between the US and Estonia while Grant has been teaching them. We went to the Ukrainian library, which is this one right here pictured. And then we went to an operetta, actually. It was really funny, but it wasn't in English, so none of us really had any idea what was going on. And now I'd like to open the floor for questions if anyone has any.
I'll ask a question. That was wonderful. We're so proud of you for doing something. I had heard some years ago about a huge problem that Estonian had with addiction, and it was kind of shocking. Did they reveal to you any thoughts as to why it was the highest addiction rate in Estonia compared to some of the other smaller countries, Latvia, Lithuania?
I think that it was just because since it's more of a central country, it's surrounded by a lot of different influences, and they're smaller. They have they have German populations. They have a bunch of people coming in and doing different things. So they were pretty easily influenced. There wasn't like a set thing that they followed. So when they saw one country doing it, they were like, oh, let's try this. And then it just, since they're so small and they didn't really have that specific rule at the time, I think that's probably why they had such a hard time with it.
It sounds like their government really embraced health
Mhm.
and influence, and some of their programs are really help. Is that the case with addiction?
Yes, their rates have gone down. I don't know the exact percentage, but their rates have gone down significantly with this diversion program. It seems they've kind of figured out how to embrace that addiction is a disease rather than, just someone doing bad things. And they've really used that to their advantage to help get those people back into society as functioning members.
So impressed. I know we have some diversion programs here, but I don't think it's anywhere to the extent they have still not accepted. That's really fascinating. We have so much to learn, right? From other countries, other experiences.
You said restricted substances was it criminalized initially in the society in their lives?
Yes. So he asked if at the beginning of this crisis, was it criminalized more so than it is now? And if society had an influence on the interventions instead of punishment? Yes, it was criminalized for a while. It was more so like us here in the US, where they kind of just sent you to jail, didn't give you a ton of help outside when you got out. And I don't really know how that came about, where they were like, okay, we need more interventions to get these people help when they leave. But I know society did have a big influence on that. I think people realized when they had family members, since it was such a prevalent issue, they decided as a whole that, we need to get these people help and we need to stop criminalizing it as much because it is more of a disease.
Where was the source? Russia?
I don't know specifically where it was coming from. I think since, again, they had so many influences, since they didn't have that specific rule at the time, that everything was just coming in at once. I think it was coming around from all over, but I don't know the specifics of where it was coming from.
I know that in Russia, there's a lot of alcohol. Is it the same in the Baltic states? Did you see evidence of a lot of overconsumption of alcohol?
Yeah, I mean, I would say yes. We would go to like dinner and stuff, and you'd see people, having a drink or whatever. We didn't really see anyone that was like too, like, drunk or whatever. I would say probably, though, it's more like normalized in Europe. So I would say based off that, I would say probably yes, but it seemed more like the fentanyl and the heroin was the issue more so than the alcohol.
I'm so excited, fascinated about your minor in addiction, right?
Mm-hmm.
I feel like I want to hear what that consists of. I wish more would, minor. You really need it.
Yeah, so I chose my minor in addiction studies based mostly off of my dad at the time. He was struggling with alcohol abuse and he unfortunately passed away last year. So I really wanted to continue my minor in remembering him mostly. But I've also had a lot of family problems with addiction, lots of aunts and uncles. So I thought that it would be a good way to help bridge the gap in my family specifically, because that's not something that my family likes to talk about. And now with me minoring in addiction studies, I can kind of help when when my aunt's talking about my uncle and saying, oh, he's doing it again. I can be like, well, like it is more of like him. It's not just him. Like, it's other stuff is going on, and I can kind of help educate them a little bit on that. And then especially here in West Virginia, for nursing, I got to go to the NICU one day, and I got to work with a lot of babies who were born addicted to substances. And I was really interested in working with them further and just kind of helping them and getting them the help that they need. And I have one more class. I'm almost finished. I do my capstone for it next semester. So I'm really excited to finish that and see where that takes me.
You're studying for Estonia, and it's also integrated and you got the experience in your minor too. It sounds like you got to rotate in different places.
Mm-hmm.
Besides the coursework,
What was the situation at the similar problem there?
I think they have more of a similar problem in Latvia and Lithuania. I don't think it's as bad. And the three, so Estonia, Latvia, and Lithuania, they are all very big cultural influences on each other. They're practically, quote unquote, the same. Like they kind of experience all the same things. They have a lot of similar cultural significance. I don't think it's as bad in those countries. However, I think that Estonia, it was the most affected. Now it's definitely decreasing in its prevalence.
Your interaction with references to Russia and the military threat, such as
Yes, so at the time that we went on our trip, it was in March of last semester. And so everything was kind of getting scary again with threats from Russia and all these other places. So we actually had to think about if we were actually going to go, because as you saw from the picture, Estonia is right next to Russia. And we went to 3 major cities on our trip. 2 of them were more of the like Ukrainian refugee side where they helped them. But then one city that we went to was right next to Russia. And so the differences between that, we didn't really hear about the Russian like invasion or anything like that. We did see this, it was like kind of a tribute to Ukraine. They had like, we were walking down the street to go to one of our other tours, and the sidewalk was just lined with posters and flowers and just memorials for the Ukrainian refugees. So there were definitely some influences. We didn't really hear people talk about them much though.
One other.
It's okay.
You mentioned earlier, in your talk, that, you mentioned Ukrainian is one of the languages spoken there. Is that since the invasion of Ukraine by Russia with refugees, or was there some sort of a tie between the 2 countries before?
I believe it was kind of there before the refugees came. Definitely now, since there are a lot more refugees, they have been trying to amp up their Ukrainian and teach other people about it. But I don't think it was as prevalent before the refugees came into the country. So real quick, this is a picture. The kid in the middle right here in the red, he's from Estonia, and he came up to us and he heard us, he saw our WVU gear, and he told us that his father was actually on the soccer team over here at some point. And so we did the horns down with him in the middle of a McDonald's, and it was, the McDonald's over there are great, by the way. If you ever need some recommendations, they're way better over there.
Thank you so much, Maleah. That was really inspiring, and it sounds like that experience was really a life-changing experience for you, as well as hearing about it for us. I mean, I think it just emphasizes so much how much we have to learn. We can learn from other countries and vice versa, you know. And we wish you all the best in the future. I'm excited also now to introduce our next speaker. And this is Dixie Shahan, PharmD. And Dr. Shahan is a WVU Hospital's PGY1 acute care pharmacy resident. And she's rotating on ID right now, so I'm not biased or anything about that. But anyway, we're so happy to have Dixie here, and she's excited to talk to us about her experience in South Africa. Her title is Equity and Disparity in the South African Healthcare System, and so appropriate for Diversity Week. Thank you, Dixie.
Thank you. So, like Dr. Fisher mentioned, my name is Dixie Shahan, and I am currently a resident at WVU Medicine, but I'm a graduate of the WVU School of Pharmacy from last year. And so whenever I was doing my 4th year rotations, I did a rotation in Cape Town, South Africa. And so that's kind of what I'm going to be talking about here today. So when the rotation experience is 4 weeks, the current year is they're actually there right now. So they do this rotation every year. It's mostly during the month of September. So the group from this year is still there right now, but I was there during this time last year. And so there are 3 students that went with us and a resident. He was like our preceptor that kind of oversaw us throughout the trip. And then the other people in this photo are the Masters of Clinical Pharmacy students from South Africa. So we had a lot of interaction with them and went to lectures with them. So they were like a really big influence on us and helped us a lot while we were there. So just to talk a little bit about the South African culture. So it's a population of 59.31 million people. There are 11 official languages, but English and Afrikaans are the 2 most commonly spoken. I will say that pretty much everyone that I interacted with spoke English. There were maybe only like 3 to 5 patients that I ever interacted with that didn't speak English at all. So it was pretty easy to interact with the patients and anyone that we interacted with there. And then there are 9 provinces. Cape Town, where we were most of the time, is on the West Coast and the Western Cape. And it is racially segregated still in the post-apartheid government. So just to give a little bit of background, so the post-apartheid government is referring to after 1994. So before that, the country was extremely segregated by race and class. So like rich versus poor, black versus white. And so in 1994, when Nelson Mandela became president, he promised to, kind of help with that and stop the segregation, as well as he promised to help with like housing and all those sort of things. So millions of people flooded to some of the bigger cities in South Africa, which I'll talk a little bit about that on the next slide, but it is still extremely racially segregated today. So even though this post-apartheid government is supposed to not be racially segregated, it is still extremely racially segregated. So that's kind of what I wanted to show with this slide. So you can see like on the left part is I'll show a closer up picture, but those are like 10 shacks that a lot of people live in. So whenever all these millions of people came to like, this is closer to like Cape Town, they didn't obviously have anywhere to go. So they built these like 10 shacks. And so that's what you'll see like on the left side, there are like millions of people that live in these, sometimes like 10 people in one of them, which I'll show you how small they are. But then directly across the road, you can see these houses that are extremely large. Some of them even have pools and gates and things like that. And it's like quite literally directly across the road from each other. So that really just shows like the inequity and like the segregation that they experience based on like rich versus poor, black versus white. So this is just a closer up picture of the shacks that a lot of people live in. And so they literally, you can kind of see like it goes for miles and miles. And like it just, our preceptor there that lives there, he kind of talked about how even over the past like 6 months it had gotten even like more and more being built. So it's like continually a problem still today. So I'm mostly going to be talking about the healthcare in South Africa because that's obviously what we mostly experience. We spent our time in 2 public hospitals in South Africa, working as pharmacy students and working with pharmacists. And so South Africa has a 2-tiered healthcare system. So they have a private sector and a public sector. The private sector is for patients that have their own private healthcare insurance. So they're able to afford healthcare insurance, which is a very small amount, which I'll go into a little bit more. But the public sector treats any patient who doesn't have health insurance. So unlike the US, where if a patient has health insurance, they can still go to a hospital and be seen. Like they can still go to any hospital and they'll be seen. Whereas here, like if you didn't have health insurance and you showed up to a hospital, they would turn you away. So it's very segregated as to the healthcare system as well, and like who can afford it and who can't. And the one thing that is the same between the two is that both of the hospital systems still utilize paper charts for record keeping of all their patient information, which was like kind of one of the barriers that we ran into with going there. But the private sector still has a lot more advances than the public sector. And so just kind of to go into them specifically, the public sector, about 80% of the population relies on the public sector for healthcare. So like I mentioned, the vast majority of patients are seen in these hospitals. It's solely funded by the government. So they have a lot of issues with funding and staff. And then there's, like I said, more than 400 public hospitals. They have really long wait times. So the one hospital that we were at, they had like an outpatient clinic, and they told us that the patients had to get there by like 6:30 in the morning just to ensure that they were seen by 2 p.m. that day. So there's just extremely long wait times. Like every waiting room we always went to was completely full of patients that had been waiting all day. There's also very little privacy there. So the first hospital that we spent time in, I worked on a ward that had a large room, probably like a little smaller than this. And there were probably like, I would say 15 or 16 patients just in like one giant room. And there's not like separation between them at all. There's curtains that they can pull, but that doesn't really happen very often. And then the medication options are really limited for them as well. So for example, obviously with pharmacy, that was a really big thing for us, knowing what medication options they had. And so, for example, they usually only had like 1 or 2 drugs from each class. So for example, like a beta blocker, they only had like 1 or 2 of them that you could use. There just wasn't an option to use anything else. And so now I'm going to talk about the two hospitals that we were at within the public sector. So New Somerset Hospital, we spent 2 weeks there. It opened in 1864 and has been declared a provincial heritage site. It's located right in the heart of Cape Town, which I'll get into a little bit more, but it's really just right in like the epicenter of this very large town. It is a 334 bed hospital, and the wards, like I mentioned, that's kind of what they refer to them as instead of units, are separated male and female. Something that I thought was really interesting about New Somerset is that they had a West Wing that opened in 1973, but the West Wing was specifically for white patients. And then the North Wing, which wasn't to signify that it was in like the north of the hospital, but just that it was for non-white patients. So still extremely segregated in that way. But it was, in this picture here is an example of like a medication cart. So the nurses only had certain times of the day that they would go around and give patients medications. And it was all, like I said, paper recording, and they just like pushed this cart around and gave meds. So much more like limited options. And then I kind of wanted to just use these next 2 photos to show specifically like the inequity. So you can see New Somerset Hospital is what's directly behind us, the yellow building. And so those patients, you know, very little privacy and just like aren't able to, they have to go to those hospitals because they don't have insurance. And you can see like, the next picture is what they see. Like you can see there's like windows there in the hospital. So this picture is what they see out those windows. So this is like a multi-million-dollar waterfront that is directly in front of the hospital. It's like you can literally, like I said, see it from the hospital. So it just kind of shows the direct like inequity that these patients are like, they don't have as much access to healthcare, but they're watching, you know, there were literally like some like high-end car dealerships here, yachts, and like all kinds of things. So it really just kind of for me specifically, it showed like the inequity of what they were experiencing. And then Helderberg Hospital was where we spent our second 2 weeks. So it was a little bit smaller of a hospital and newer, built in 1939, 162 beds. We worked on E ward, which was an all-female ward. Like I mentioned, still not very much privacy. There were like 4 rooms that had about 6 or so patients in each one. And they also had some like isolation rooms for tuberculosis patients and other patients with like highly contagious diseases. And then they had what they called a high care ward, which was kind of similar to what we would refer to as like an ICU maybe here. But there were only 4 beds in that unit. So they didn't really have much in terms of being able to take care of like super high acuity patients. And then at this hospital, they only did rounds on patients once a week. So as you guys know, I'm sure at most hospitals here, we do them once, if not more, every day. They did these like once a week. And so the next is just some photos from that hospital. And then the private sector. So like I mentioned, 80% of patients use public sector hospitals, but 80% of physicians work at private sector hospitals. So even though they only serve 20% of the population, the vast majority of the physicians work in the private sector. They have more modern facilities, and they have like more access to specialists and more physicians. So their facilities, we went to one of the smaller hospitals, and it was very similar to like a hospital you would see here. Like it was very new, and just the things that they had. I mean, they still had paper charts, but everything was still very similar to what we see here. And then most of the hospitals are for profit. So like I mentioned, they do have varying levels of coverage. So similar to here, it kind of depends on what insurance plan you have, what coverage you can get. And patients could technically pay out of pocket for their services, but obviously if they can't pay for insurance, they probably can't pay out of pocket for medical coverage. And then they also have basically unlimited medication options. Now, it's not this what we have here. You know, we can basically get any med you want here in the US. It's not that unlimited, but compared to the public sector, it does have a lot more options. And this is an example of one of the private sector hospitals. So this hospital was also in the heart of Cape Town, so one of the big cities. This is the Christian Barnard Memorial Hospital, which, just for like some background, Christian Barnard performed the first human to human heart transplant in 1967. So that's kind of why it's named after him. But as you can see, looks just like a hospital like you would see here in the US. So community health clinics are one of the big ways that the public sector patients get health care. They are able to like be seen by a physician. They can get medication given to them, and that's where most of them will pick up their like prescriptions that they take. So most of them don't get them from like a retail pharmacy. This is where they would get their medications from. And then over 3,500 clinics do provide free healthcare to pregnant women and children less than 6 years old. So just to give a little bit about pharmacy in South Africa. So like I mentioned, most patients won't get their medications from an from a like quote unquote chain pharmacy. But this is a picture of one of the pharmacies that I went to there. Something that is a little bit different to the chain pharmacies there is they don't have hardly any medication, like over-the-counter medications, just out for patients to buy. Pretty much every medication you had to ask a pharmacist for. So like I was sick while I was there and had to like buy some medications, and I had to ask a pharmacist and tell him like what was wrong. And, so I think it's like the max they can do is like 20 tablets of like ibuprofen or something. Like, it's very small amounts if you can get anything without like speaking to a pharmacist. And so one of the biggest reasons that we go to South Africa is to kind of try to advance the clinical pharmacy aspect. So if you've been in a hospital, especially here at Ruby, we have pharmacists everywhere, whereas that's not necessarily the case there. They actually, there are only about, I think it's 8 PharmDs in the entire country of South Africa. So they mostly have bachelors of pharmacy students, but our preceptor, he's one of those 8 PharmDs in South Africa. And so they mostly have, like I said, the BS Pharm degrees, but they have this Master's of Clinical Pharmacy at the University of the Western Cape, which are those students that I showed a picture of at the beginning. They are kind of trying to, in addition, help advance clinical pharmacy in South Africa. So they, even though there aren't like clinical pharmacists that work on the units there, they kind of fill that role in being students. So at New Somerset, there were like 4 students that were there every single day, which they kind of rotate around like we do. But it definitely, I think, is helping physicians be used to pharmacists making interventions, because the doctors that we encountered were very welcoming. But based on stories that I've gotten from Dr. Wheatholder and some other people that have been on this trip, that's not always been the case, just because they're not used to, having pharmacists on their service. So then the next 2 slides, I'm going to kind of talk about the 2 big things that we encountered while we were there. And one of the things that really shows the like equity and disparity of their healthcare system. So the first one being HIV. So as of 2020, South Africa had the highest number of cases of HIV worldwide, with 8.2 million adults and children living with HIV in South Africa. And just kind of to give you like a reference for that, during that when that statistic was given, 8.2 million, there were 1.2 million people living with HIV in the US. So it just kind of shows you that vast difference. And then 67% of people living with HIV are on antiretroviral therapy and have a suppressed viral load, whereas only 57% of people in the US with HIV are on ART and virally suppressed, which there is a large stigma around HIV, especially here in the US. So we think that, and that is kind of attributed to the difference there, but a large number of patients are lost to follow up. So that's kind of what attributes to that as well. And then the availability of those antiretroviral therapies are much more limited. So in the US, we have like so many different HIV medications. No matter, it's pretty much anything you could want, we have it here. And whereas they were very limited in what they had, and pretty much any patient, unless they had some sort of like resistance, they were put on the same medication. So then tuberculosis, which is one we very rarely see here in the US, it is the leading cause of death in South Africa. And South Africa is one of the 30 high burden TB countries that accounts for 87% of cases worldwide. With the estimated prevalence of TB in their country is 737 per 10,000 per 100,000 persons. And once again, just to reference that back to how serious it is in 2018, the US reported a TB prevalence of 2.8 cases per 100,000 people. So it really just shows the very stark difference in what they experience there. And then 80% of people just that live in South Africa are infected with TB. Most of them have latent TB, but it's definitely much more of like a lax disease to have there. The first day that we were there, we were like going on rounds, and one of the patients that we were talking about they were like, oh, we think she has TB. She wasn't wearing a mask. She was, like I said, in a room with 15 other patients. And then the next day she like tested positive for TB. So it's just something that it was taken more seriously with COVID, like as far as masking and those types of things. And they do have like TB wards there for patients, but it's definitely a lot different. And then in 2019, 58,000 people died of TB. And for reference, once again, in the US in 2019, 526 people died from TB. So it just shows you, once again, that very stark difference in the US versus South Africa. And so kind of just to wrap it back to my experience and how it differs from healthcare in the United States. So like I already kind of mentioned, sanitation and safety. So the availability of like patient beds too was like a huge issue. You know, they were always trying to like get patients out in order to get more in. There was always people waiting to get in. And then I already kind of mentioned like with the sanitation as far as like mask wearing, which most of them were wearing masks like while we were there, which it was kind of this was last September, so pretty much towards the end of COVID, but like they were all still wearing masks. And then as far as safety, so they really had very few nurses. So there would be like on the ward that I worked on that had maybe like, I would say probably like 20, 25 patients within like 2 large rooms. There were only like 2 nurses for that entire area. So it just makes it really difficult for them to like adequately care for the patients. And then as far as privacy, like I mentioned, they don't have HIPAA there. So you were in this large room just talking about all the patients next to each other. And then a lack of labs. So this was something that I really struggled with, you know, being here in the US and like having everything like at our fingertips. So for example, like a warfarin patient might not have their INR checked for weeks. They also diagnosed a lot of like heart failure off of chest x-rays, which like, you know, just they deal with what they have. And it's actually really inspiring to see what they can do with the little that they have. And then like I already kind of talked about the paper medical charts. And so I'm going to end with this patient case just because I feel like it really shows the disparity of their healthcare system. So this was one of the patients that I encountered during my 2 weeks at New Somerset Hospital. So he was 23 years old, got referred from a clinic because he was having like weakness, inability to stand, and he had been diagnosed HIV positive in early July 2022. So like I mentioned, this is in September. So a few months earlier, he'd been diagnosed with HIV, and then he came back at the end of July. And he was tested for a lot of different things, but one of them being cryptococcus. And so he had a positive cryptococcal antigen test whenever he was there in July of 2022, but they end up not really addressing that. They diagnosed him with pulmonary TB, even though he didn't have any symptoms of TB. The tests that they do for confirmation of TB were all negative. And so they did draw blood and cerebrospinal fluid cultures for cryptococcus for the patient, but the patient was discharged before those results came back. So a lot of times with cryptococcus, it takes a long time to grow, sometimes like 7 days it can take or longer. So they discharged him because once again, they needed the bed. So they went ahead and discharged him. And then 3 days after he was discharged, those blood cultures resulted positive for cryptococcus neoformans. There was no growth on his CSF culture, but he did have it in his blood. So then, like I mentioned, I saw him in September of 2022, and they did another cryptococcal antigen test, which was positive. He had no signs of meningitis, which is normally where we see cryptococcus manifesting as cryptococcal meningitis. And they tried to get a lumbar puncture, which was unsuccessful. So they kind of had to move forward with the diagnosis of that he didn't have meningitis, that this was more of like a disseminated cryptococcus infection. And just of note, his CD4 count was 13. So if you're familiar at all with HIV, the you kind of become at risk for cryptococcus at CD4 counts less than 100. So this patient at risk for basically all the opportunistic infections. And so the treatment that they gave him was amphotericin B, deoxycholate, and fluconazole. And so here in the US, just to kind of show the differences, we would have used a liposomal formulation of amphotericin B because of how nephrotoxic it is. And then with fluconazole, we normally would use flucytosine, but they didn't have access to that in South Africa. So there were things, information sent out that it was just not available. And so there have actually been studies done that flucytosine and like patients that got flucytosine survived more than when they didn't. So that was like a big thing with it. The patient was extremely confused. He couldn't really communicate with us most of the time. He developed an acute kidney injury and really severe infusion reactions. So like I mentioned, amphotericin B is one of those medications that's really hard on your kidneys and can cause some very severe infusion reactions. So this patient, he developed like an acute kidney injury. They had to end up like skipping a day of amphotericin B therapy. And then as far as infusion reactions, the day that I specifically saw him, which was one of the last days I was at the hospital, he was like visibly having rigors and like shaking really bad from the infusion reactions because they didn't give him Tylenol before they gave him the medication, which was supposed to happen. It's just that, with the lack of nursing and all the things that had happened, he didn't get it. And so, we got in contact with what they would refer to as like a resident there. So they have kind of different names for them, but it would have been basically a resident there and asked them, can we give this patient something? Because he was obviously very clearly suffering. And they said there wasn't like an attending in the hospital and they weren't comfortable like giving the patient any like IV Tylenol since he couldn't really take anything by mouth. So it was just it was really hard to watch, just for a patient that young to be suffering so greatly and not being able to do anything about it. And then, so like I said, we saw him and then that was one of our last days at that hospital, but the other students stayed. And on day 6 of his hospitalization, right after we left, he was transitioned to pain control and palliation measures and passed away shortly after that. So it was just a really eye-opening experience for me personally, because knowing that like maybe this patient could have survived if he was here. So it's just like was really difficult to, navigate those sort of things as well. So I just kind of going to end with this, like 3 ways that I would describe this experience. So it's extremely life-changing for me, very eye-opening, a once in a lifetime experience. I recommend if you ever have a chance to do it because it has changed the way that I view pretty much everything. So it was a really cool experience, and to be able to experience healthcare in another country was really interesting as well. Questions do you guys have?
Go ahead, Sarah.
I think some great stuff. I'm glad you had the opportunity to do this. When you were in South Africa, did you learn the potential of falsified or something that you wrote?
No, not that I can remember that was something that they worried about necessarily. No, I don't think so.
Regarding antiretroviral drugs, I
Mhm.
remember years ago, it first came out for treating AIDS. Countries like South Africa proposed that they be able to produce them without against patent protection. And my question is, you said that there were limited drugs available. Are those produced locally, and that's why they're limited, and they don't import ones from Europe or elsewhere? What is the reason why they're?
I think it's just simply because of like resources and cost reasons. So we have like probably 20 different HIV medications here. And I think it's just for the fact that it happens so frequently there that they have like a regimen that they start everyone on. And then sometimes it will change based on like resistance patterns. So a lot of times they'll start all these patients on the same drug, and then years and years go by and they start to develop resistance to it, like the strains of HIV. And so I don't know particularly if they like produce them there, not that I'm aware of, but I just know that it's mainly because of like reasons that they can't just keep, like I said, even with beta blockers that are super cheap medications, they only have like 2 that you can choose from at their hospitals. So it's not necessarily that, it's just, and like I said, this is all like public sector hospitals that I was experiencing. So I think it's more just like of a resources thing.
Not to say
Yes, virtually yes. Pretty much everything. They have a lot, like I said, it's not to the extent of what we can get here. So they can't get all of the like new drugs that we get here. But whenever they go to if they went to a private sector hospital, yeah, they can pretty much get any medication that they would need. And they have a lot more accessibility as far as like imaging and labs and all those things. Now there is still, some issues as far as they have a lot of issues with like electric grids and things like that there. So that can affect like sometimes all of the hospitals. But yeah, pretty much a lot of the issues, especially with that specific patient, probably would have been solved even if he was in a private sector hospital.
If you were talking to me, I was thinking about the situation in South Africa compared to our own situation here in the United States with disparity in healthcare and health equity. And they have our apartheid is gone, but there's so much segregation, even physically. So that was really stark. And huge disparity in healthcare, probably outcomes, but in the United States, we slavery is supposedly outlawed, and there's still tremendous health disparities, right? Inequity in this country, even though formally, slavery's ended and civil rights movement and everything, but we have a long way to go. Each in our own way, don't we?
Yeah.
Thank you so much. That was really illuminating.
Thank you.
And it sounds like another life-changing experience.
Yeah.
Life-changing experiences, but I hope they were inspiring to the others. Do something like this if you can. Reach out, even if you don't leave the country, go somewhere else in the United States where it's different from where you live. And we hope for the hope of the future. Thank you so much.
Thank you.
Thanks everyone for coming in.